And this is a very preliminary slide because it shows what is very well known to all of you, is a meta-analysis of about 400,000 individuals from randomized clinical trials on hypertension mainly. And it shows that when blood pressure is reduced, not much, but by 5 millimeter mercury, as you can see, there is a systematic reduction in the risk of cardiovascular events. And this is true not only in individuals in primary prevention, that is, individuals who didn't have any cardiovascular event in the history, and in secondary prevention, that is, individuals who had in the history a stroke, a myocardial infarction, heart failure, and so forth. And you can see that protection extended to all hypertension-mediated outcomes, cardiovascular events as a whole, stroke, coronary disease, heart failure, cardiovascular mortality, and even all-cause mortality. Now, these data mean that hypertension is indeed a very important cardiovascular risk factor, but that this is a not irreversible cardiovascular risk factor. If blood pressure is reduced by treatment, then the hypertension-related risk can be reduced. And this means, of course, that for a physician it's mandatory to reduce an elevated blood pressure to protect individual patients. Which drugs should be used to reduce blood pressure? Now, of course, all individuals have to have non-pharmacological interventions to correct erroneous lifestyles. But in the majority of hypertensive patients, those with the blood pressure above 140 over 90 millimeter of mercury, well, this is not enough. And in most of them, antihypertensive drugs have to be used. And so the first question to address is, which are the criteria to select what we can call the major antihypertensive drugs, those who have been considered first to reduce blood pressure? In the recent guidelines of the European Society of Hypertension, 4 criteria were set to select these major antihypertensive drugs: effective blood pressure reduction, evidence from placebo-controlled randomized clinical trial of cardiovascular protection, evidence against placebo-controlled groups that this protection involves the major consequences for hypertension, that is, increase the risk of coronary disease, heart failure, and stroke. And then the last criterion has been in comparison trials, one drug versus another, for example. Well, the evidence that overall, during treatment, the incidence of cardiovascular events is similar to that of other major antihypertensive agents. Well, reduction in blood pressure is the first criterion. And here you have data from a very large study, 40,000 patients, compared to a high number of individuals under placebo. And you can see that 5 drug classes largely used in hypertension, thiazide diuretics, beta blockers, ACE inhibitors, angiotensin receptor blockers, and calcium channel blockers, had a clear-cut reduction in systolic and diastolic blood pressure when they were given to the patient. And this was dose-related. That is, the higher the dose, the greater was the blood pressure reduction. And the magnitude of the blood pressure reduction was quite similar between these 5 major drug classes. Now, this first criterion is extremely important because we do have a lot of evidence that there is a relationship between the magnitude of blood pressure reduction per se and the magnitude of cardiovascular protection. This is taken from a meta-analysis against, and you can see that as blood pressure reduction became greater, the magnitude of the protective effect on treatment, that is the reduction in cardiovascular events, also became greater in a linearly related fashion. So the protective effect of treatment of hypertension is largely related to blood pressure reduction per se, regardless which drug is used. And there is another piece of evidence on this, very important. This is a very well-known meta-analysis published a few years ago from the collaborative group, and it shows the risk of cardiovascular events when different drugs were compared for a similar reduction in blood pressure here. And you can see that for a similar reduction in blood pressure, there was very little difference in the risk of cardiovascular events between different drugs. And this is another piece of evidence in favor of the fact that it is extremely important to reduce blood pressure, because reduction in blood pressure is protective, again, per se, regardless which drug has been used to reduce blood pressure. Then the second criteria, evidence from randomized placebo-controlled trials of cardiovascular protection. And you have the 5 drugs here versus placebo, reduction in blood pressure in the top lines. And please notice that all these favored drug classes, beta blockers, diuretics, ACE inhibitors, angiotensin receptor blockers, and calcium channel blockers, were capable of protecting hypertensive patients when blood pressure was reduced by using these drugs. Then the protective effect of treatment compared to placebo against the major outcome types, that is stroke, coronary disease, and heart failure. And here you have data from a very famous meta-analysis, more than 300,000 patients, published in 2009, all placebo-controlled trials, and showing that these 5 drug classes, as you can see, were capable versus placebo to reduce coronary events, heart failure events, and stroke. So the major hypertension-related events are all protected by antihypertensive treatment, no matter which of the 5 drugs is used. Don't compare between drug differences, because one cannot compare across trials, because of course the trial conditions are different from one trial to another trial. And then the fourth criterion, that is what happens when one drug class is compared to the others. Diuretic versus all other drugs, beta blockers versus all other drugs, calcium channel blockers versus all other drugs, and so on and so forth. And I would like you to notice that for a similar reduction in blood pressure, there is, once again, no significant difference in the protective effect of one drug versus the others. And this is true in primary prevention, this is the green square, or in secondary prevention, the orange square. And this reflects what I've shown you before, that is that probably the reduction in blood pressure per se is the most important factor in protecting patients. Doesn't mean that drugs don't have a blood pressure independent protective effect. They do. But as far as antihypertensive treatment is concerned, no question, the major protective factor is blood pressure reduction. Now, thiazide and thiazide-like diuretics appear to have a similar protective effect. They are among the 5 major antihypertensive drugs. It doesn't really matter as far as protection is concerned whether one uses thiazide, diuretics, chlorkalidone, or indapamide. This is again data from a meta-analysis. The event here is stroke, and you can see that more or less the protective effect is similar with different types of diuretics. So because of these results, the guidelines of the European Society of Hypertension have come up with the so-called diamond figure. That is, 5 major drugs have to be regarded as major drugs for the treatment of hypertension. That is diuretics, thiazide and thiazide-like, ACE inhibitors or angiotensin receptor blockers, calcium channel blockers, and also beta blockers. Now, there are some other recommendations as far as drugs are concerned. Of course, there are other drugs which can be used in hypertension, what have been called additional drug classes, steroidal mineralocorticoid receptor antagonists, loop diuretics, alpha-1 blockers, centrally active agents, vasodilators. Well, they had to be used in many patients, but they are not regarded as major drugs because they do not have evidence of cardiovascular protection in randomized placebo-controlled trials in hypertension, in addition to some other inconveniences. But they had to be added to the major drugs when the major drugs are not sufficient to control blood pressure. And then in recent guidelines, attention has been directed to new antihypertensive drug classes, ARNI, SGLT2 inhibitors, related to antidiabetic treatment, but also important for antihypertensive treatment. They also have a blood pressure lowering effect, in addition to be protective for the kidney and the heart. And new non-steroidal mineralocorticoid receptor antagonist. And these drugs have been recommended not for the general hypertensive population, but for conditions such as resistant hypertension, heart failure, and chronic kidney disease. Then additional information from the diamond figure, which I want you to see in a clearer fashion, is how to use these drugs. Of course, one should start with a lower dose of the drug, although not the minimal dose, a drug which is effective in reducing blood pressure. Try to use drugs which have to be given on a once-a-day basis because treatment simplification is important for adherence to treatment. Morning assumption of the drug should be preferred because morning assumption has been used in most trials, and recent evidence shows that there is not a preferential effect by giving the drug at the time of the bedside. Single pill combination, I already mentioned, and then to start with 2 drugs, but this is part of the new treatment strategy and will be the topic of another lecture. Now, what was very important in the guidelines of the European Society of Hypertension published in 2023 has been in particular that beta blockers have been placed at the same level as the other drugs. So not only diuretic, ACE inhibitors, angiotensin receptor blockers, and calcium channel blockers were regarded as the major drug classes, but diuretics was placed at the same level. And combination of diuretic with all these other classes was also considered as a major antihypertensive treatment strategy. Why this was the case? Because by all criteria used, as you have seen, beta blockers, fit it with really no difference from the other major drug classes. So there was, on the basis of evidence, no reason not to place beta blockers at the same level as the other drug classes. And this was the case also if we consider the combination treatment. And combination treatment, I can anticipate something regarding treatment strategy, is now considered as the major therapeutic tool we have to control blood pressure. Only a minority of hypertensive patients respond to a single drug. Most of them need at least 2 drugs to come to blood pressure control. And here you see, if you look at the red colors, that beta blockers have been shown to be protective in a number of trials in which beta blocker was used together with another drug, diuretic, angiotensin receptor blocker, calcium channel blocker, and even ACE inhibitor. So this is the demonstration that not only monotherapy, and I showed you in the criteria which I discussed in the first part of my presentation, but also in the very common type of treatment, which is combination treatment, beta blockers have to be considered as at the same level as the other drugs. And this is a slide showing comparison of combination treatment, including beta blockers. Now, we do have two trials, LIFE and ASCOT, in which beta blockers lost the confrontation, but you can see that in quite a few other trials did not show any significant difference between beta blocker combined with another drug compared to a combination in which beta blockers were not included. Now, one other consideration which was made by the guidelines of the European Society of Hypertension is that, as all drugs, beta blockers do have some inconveniences. In the case of beta blockers, for example, you know that in the past, beta blockers were regarded to have a couple of contraindications, peripheral artery disease and obstructive lung disease. Side effect profile is considered to be less favorable compared to blockers of the renin-angiotensin system. Beta blockers have been associated together with diuretics with greater treatment discontinuation, and they are regarded as being less effective against asymptomatic preclinical organ damage, and also to have metabolic or produce metabolic abnormalities, such as, for example, new onset diabetes. Now, what the guidelines discussed has been that contraindications of the use of beta blockers in peripheral artery disease and obstructive lung disease doesn't exist anymore, because evidence has been shown, has been produced that these drugs can be safe in these conditions, and in fact they can be protective because these conditions are frequently associated with coronary heart disease, which is a specific preferred indication of beta blockers. Then it is true that some side effects have been overestimated when studies have been limited to control protocols. Well, some of the so-called side effects of beta blocker have been much less. Now, then, large use of combination treatment, which is done today, of course, reduces the risk of having a side effects, because in combination treatment, doses used are smaller, and side effects are in general dose related. And so, in addition, consideration has been given to the fact that beta blockers are not a homogeneous, but an heterogeneous class. And this is stated in the guidelines. I mean, when beta blockers have beta-1 selectivity or an additional vasodilator property, then all the previous side effects I've shown to you, I mean, is maximally minimized. But what I need to address is another inconveniences, which is frequently mentioned when we talk about the use of beta blockers in cardiovascular disease, in particular hypertension. And this is the beta blockers are talked about not having a protection against cerebrovascular outcomes or stroke. This has come from meta-analysis of randomized trials, and a couple of them have participated, in which beta blockers have been compared to other drugs, and the risk of stroke has been greater with beta blockers than with the comparison drugs. Now, it is difficult to explain this finding from meta-analysis, because if you look at placebo-controlled trials, and I've taken 5 of these trials, very important trials, so very well known, some of them published a number of years ago, well, you can see that compared to placebo, use of beta blockers has been associated with a major reduction in stroke. In the Coop and Warren trial, for example, use of beta blockers in combination treatment, because at this time combination treatment was largely used. I mean, there was a 42 reduction in stroke. In the very famous STOP trial, there was a 38 reduction, a 45% reduction in stroke, I'm sorry. So there is absolutely no question that against placebo, beta blockers can markedly reduce stroke. This is a very famous meta-analysis published in 1995. We will refer to this meta-analysis for several years. It was a meta-analysis based on 5 placebo-controlled randomized trials published by some famous meta-analysts, Professor McMahon from Australia, Professor Collins from UK. In 4 out of these 5 placebo-controlled trials, the key treatment was a beta blocker. And in this meta-analysis, which for the first time in a meta-analytic fashion showed the protective effect of antihypertensive treatment, as you can see, treated people had a 39% reduction in stroke. So absolutely no question that if we give beta blockers to our hypertensive patients, we can reduce maximally the risk of stroke. Now, the second puzzling point for guidelines has been that there are no data on any possible direct traumatizing adverse effects of beta blockers on stroke. I mean, there is no evidence that beta blocker has an adverse effect on the brain matter. There is no evidence that beta blockers impair cerebral blood flow autoregulation. Could be that the greater treatment discontinuation associated with beta blockers is responsible, but if so, then we should see a greater risk of not only of stroke, but of all hypertension-related cardiovascular events, which is absolutely not the case. So what the guidelines discuss has been the possibility that what we see in this comparison meta-analysis depends on the fact that in some trials, for some unknown reasons, beta blockers reduce blood pressure less than the comparison drugs. And we know that stroke incidence is extremely sensitively related to even small reduction in blood pressure. And this has been corroborated by this meta-analysis, which has shown, once again, like the previous one I've shown you, that when compared to the other drugs, beta blockers had a greater risk of stroke. But this was not the case when the comparison was limited to beta blocker versus blockers of the renin-angiotensin system diuretics, with the exclusion of calcium channel blockers. And what really was the result was that it was the calcium channel blocker compared to the other drug classes that was associated with a reduction in stroke. Now, the hypothesis, which has been discussed by the guidelines, is that the unexplained results of the comparison trials on stroke could have been due to the fact that in some trials, well, the reduction in blood pressure has been less for beta blockers than from other drugs. And this has been in particular supported by the fact that trials with beta blockers I've been showing to you have made large use of atenolol. And we know that atenolol has a relatively short duration of action. And a dose of atenolol, 50 milligrams per day, as the one which was used in these trials, well, could have, for example, reduced blood pressure, not for entire 24-hour time, but only for maybe 16 hours or 14 hours, leaving a fraction of the between dose interval unprotected. Now, interestingly, some years ago, with my mentor, Professor Zanchetti, we look at what happened in one of the trials in which there was a blood pressure difference between the beta blocker group and the comparison group, which was treated with the calcium channel blocker. And this was the ASCOT trial. In the ASCOT trial, beta blockers were less protective against stroke, but in the beta blocker group, the fall in blood pressure was 3 millimeters mercury less than the comparison group. And you can see that these 3 millimeters of mercury had an effect on stroke, which was along the line of the collaborative group meta-analysis, which showed the protective effect of blood pressure reduction on stroke. The greater the blood pressure reduction, the greater the protective effect on stroke. And maybe it is a coincidence, but it is very interesting that these 3 millimeters of mercury had an effect on stroke, which almost precisely fell on this regression line. In addition to this, it was, of course, important, particularly for a medical world which is moving towards precision medicine, the fact that beta blockers do have a number of specific conditions in which they have to be preferred. So this is now a problem of choice, but it is a mandatory choice in a way. And as you know, this is symptomatic angina, the post-myocardial infarction state. Heart failure, and according to the guidelines, not only heart failure with reduced ejection fraction, but also with preserved ejection fraction, aortic dissecting aneurysm, individuals with a heart rate above 80 beats per minute, and atrial fibrillation, in which beta blockers are necessary in quite a number of patients in order to control heart rate. And a further consideration of the guidelines based on a paper which was published just 1 year before the guidelines is that in clinical practice, beta blockers, one way or another, had to be used and are used in a number of conditions for symptomatic reasons sometimes. And these conditions are conditions related to cardiac diseases, to vascular diseases, and even to diseases which have nothing to do with the blood pressure abnormalities. For example, migraine, essential tremor, glaucoma, just to mention a few. So I think that it was, in a way, mandatory for the 2023 guidelines to place beta blockers together with the other drug classes. And I think this is an evidence-based recommendation. Thank you very much for your kind attention.